All right, we're going to go ahead and kick this off. Welcome. I'm Connie Sullivan. I'm the president and CEO of the National Home Infusion Association. And also joining me today is Bill Noyes, who's our senior vice president of reimbursement policy for NHIA. And we wanted to offer this home infusion legislative and policy briefing because obviously there's been a lot of activity around home infusion legislation earlier this year. And we have two bills that we want to discuss today, and they have very similar names and they impact the same benefit, but do very different things. And so we wanted to offer some clarification about these two policies, what they do, what they don't do, and the difference between the two of them, and a little bit more about how we think they'll impact the industry. So I'm going to go ahead and dive in to the slides. Just a little bit of housekeeping before I do introduction. I guess I've already sort of done introductions, but the slides for today's webinar are in the chat. You're welcome to download those. And then if you have questions as we go through the webinar, please put them in the Q&A, not in the chat. But if you have any technical problems, put those types of things in the chat. And I do have some team members backstage that can help resolve any technical problems you might have. So please use the Q&A for your questions, and we'll hopefully have time at the end to address them. So again, we are your presenters today. I do see a raised hand, so I'll let the team maybe see if that's a technical issue. Okay, so our agenda for today, I said I had two policies to review with you. The first being the Preserving Patient Access to Home Infusion Act, which is an NHIA-sponsored bill that has been introduced into this Congress as of last year and would make many changes to Medicare's coverage for home infusion. And then also I want to talk about the Joe Fiandra Access to Home Infusion Act that was recently passed as part of a package earlier this year in January that will have an impact on Medicare coverage as well. So let's start with the Preserving Patient Access to Home Infusion Act, which is legislation that we have been working on for quite some time to try to improve access for Medicare beneficiaries. And it targets benefits that are currently in effect in Medicare Part B, and we'll go through that in more detail. Our House sponsors are Representative Vern Buchanan out of Florida and Representative Debbie Dingell in Michigan. This bill is bipartisan and bicameral, so we also have a Senate companion bill sponsored by Tim Scott in South Carolina and Mark Warner in Virginia. Currently, to date, we have 26 House co-sponsors. Our sponsors in the Senate are basically our two bill sponsors. That's not unusual. We are very much, for our process of working toward passage, focused on the House, and that is where our efforts are today. So I think it's important that first, before we dive into this, for those of you who haven't been following this along and are joining us today and maybe not part of the home infusion community directly, or a different stakeholder, maybe in the financial world, we want to do a quick review of the benefits that these bills impact and where they sit in Medicare. So basically, home infusion coverage for Medicare beneficiaries lives in Part B under the durable medical equipment benefit. So we refer to that generally as DMEPOS. Within that benefit, there are several different home infusion benefits, but this bill in particular is focused on the external infusion pump benefit, not parenteral or enteral nutrition. It also does not impact the newly created immune globulin benefit for primary immune disease, which started out as a demonstration several years ago. So the external infusion pump benefit is the benefit that is impacted by these bills. And the DME benefit for home infusion works in conjunction with a services benefit that was created in 2016 with 21st Century Cures called the Home Infusion Therapy Services Benefit. So when we talk about the Preserving Patient Access to Home Infusion Act and also Joe Fiandra, we're really talking about how it impacts and changes these two policies or references these two policies. It's really important to understand this is a pump benefit, not a home infusion drug benefit. That there are drugs that are covered because they are dependent on the use of that external infusion pump. So Basically, we're talking about a very small number of drugs that are for subcutaneous infusion of immune globulin, continuous chemotherapy, continuous infusions of drugs for heart failure, and other kind of conditions. So, very, very small benefit. Bill, do you want to add anything here about the benefit that I might not have mentioned?
No, I think you covered it. I just point out that the external infusion pump benefit is just that. It's based on coverage for the pump, and the drug is considered a supply to the pump. So it's very different than what we see in the commercial space where there's coverage for a home infusion therapy. This is really based on the need for a durable piece of equipment, the infusion pump.
Thanks. And then just to kind of mention quickly the HIT services benefit, which is also a Part B benefit. Basically, this covers nursing services that are provided face to face for the drugs that are in the EIP benefit. So I'm going to refer going forward to the EIP benefit, which is the infusion pump benefit. I just want to check the chat here, make sure we don't have some kind of technical problem where people aren't hearing us. Uh, okay, people are just asking questions about slides. Okay, so yeah, the slides are already in the chat. So you can look at the slides or download the slides at your convenience. All right, so these are the benefits we're going to be talking about as we go through these bills. I do want to also point out, though, that there are a lot of gaps in the Medicare home infusion coverage. So because it covers an infusion pump and not drugs, it leaves out a lot of drugs that we use very commonly in home infusion for commercial insured patients or patients with TRICARE or Medicaid, pretty much any payer except for Medicare. And then the services gaps, because it only covers a portion of home infusion services, meaning the nursing services that occur in the home, it means that the pharmacy services that we are providing behind the scenes as home infusion companies, pharmacy services that provide assessments, coordinate the care, be available 24/7, provide sterile compounded medications, care planning, and more, etc. Those are currently not covered by this benefit. So that is still a coverage gap in this benefit. And one of the primary reasons that there are so few providers today participating in the benefit. On the drug side, common drugs that have no coverage under the Medicare benefit are IV antibiotics. There are some antifungals and antivirals that are included in the benefit, but again, not commonly used products. All monoclonal antibodies for chronic conditions, those are not covered. If you're a parenteral nutrition patient, you know that maybe some of your drug additives are not covered under your PN benefit. They're also not covered here. And then there are drugs that use infusion pumps, and those are not covered because this coverage policy is very specific to whatever drugs get added to this policy.
Connie, there is a question, and if you
Uh-huh.
back up one slide, I think now is the time to address it.
Okay.
Doesn't the EIP, the external infusion pump benefit, cover IVIG, that's intravenous immune globulin, for certain diagnoses? It does not. It is covered under DMEPOS under a separate policy, and that is the intravenous immune globulin policy specific for primary immune deficiency disease. So I hope that answers that question.
And we're going to come back to IVIG in a little
Mhm.
detail here in a few minutes. So I want to tell you first what the Preserving Patient Access to Home Infusion Act would do if it were passed. Basically, it would close a lot of the gaps that exist in the current Medicare benefit. So it would add a payment for pharmacy services that are not provided in the home, and it would do it in a way that mirrors how we function in the commercial market. It would also bundle the supplies that are billed separately today for the pump and for the catheter into that per infusion day payment. So that would be a fairly significant change to how the benefit functions today, but it would be very familiar to home infusion providers because this is how we operate with pretty much every other payer. It would also establish the rate for those pharmacy services at 50% of the current nursing rate, and it would freeze that rate for 5 years. And that's basically to allow time for providers to enroll in the benefit, have some stability, have some predictability in terms of what the rates will be, because there's processes for pharmacies that want to enroll in the benefit, go through accreditation. That can take time and is a financial investment. And so we want to create some certainty with this benefit to encourage providers to participate. And that's what that would do. Finally, the other really big thing this bill would do is add coverage for IV anti-infectives of all types, including IV antibiotics. And it would not be dependent on the need for a pump. So that's a really big change as well. And it would allow those anti-infectives to actually continue to be billed under Part D, as in dog, instead of having to move those drugs into the Part B benefit. And the reason for that is that patients typically pay less for drugs in Part D and have that cap on out-of-pocket costs compared to Part B. And those drugs are already covered today in the Part D benefit. So that's essentially in a nutshell what our bill would do. The status of our bill is that we were included in an Energy and Commerce Subcommittee hearing in January of this year, which is a really positive step forward. It signals that Congress is interested in passing this bill this year, and it allowed us to take questions from members of Congress about what the bill would do, what the impact of the bill is, what the impact is for not passing the bill as well. And it allowed us to go on record talking about how Medicare patients, unlike everyone else in the United States, those patients have to drive back and forth to facilities if they need antibiotics after a hospital discharge, or even for antibiotics that might be initiated in the community setting. It would allow those patients to finally receive those at home if they're appropriate. The next steps for our bill, we are still waiting on something called a CBO score. The Congressional Budget Office, that's what CBO stands for, has to provide a score for every bill to indicate what the impact of that bill would be on the budget. And so we're waiting on that process. We have met with CBO many times. We've answered a lot of questions for them, and we feel confident that they could produce a score. They always have a lot on their plate, so it's always an effort to get members of Congress and committee staff to make this a priority for them. And then the next step in the process is to continue to work our way through our committees of jurisdiction. So in the House, that's Energy and Commerce and Ways and Means. And we are hopeful that we will go through a markup in one or both of those committees later this year. What would it mean if we pass this bill? So first and foremost, there are about 1 million Medicare beneficiaries today that travel to an office setting for an IV antibiotic or other type of anti-infective. That's a lot of beneficiaries that could potentially be converted to home infusion patients. Now, obviously, not all of them are going to become home infusion patients, but I do think that's a lot of chair space, that's a lot of staff time, that's a lot of potential burden to hospital staff for patients that don't necessarily need to be coming back to that facility. And so we do believe a very large percentage of patients who are in HOPDs today could potentially be referred to home infusion. We also see patients that end up going to long-term care facilities for IV antibiotics. So we think that this would be a popular benefit, and that's evidenced by the popularity of IV antibiotics for home infusion in the commercial space. It's by far the largest therapy that is provided at home. And we think this is the standard of care today. It's just that Medicare beneficiaries do not currently have access. Because of the opportunity to serve such a large number of beneficiaries, we do believe it would encourage home infusion providers today who don't participate in the Part B HIT services benefit to enroll. And that would improve access for all patients who are in those benefits today. And we also think it would improve access for patients who are not Medicare patients, because now there'll be more providers potentially that can support the infrastructure to have their facilities, and maybe even opening new facilities in markets where we see deserts today and there's not home infusion access. So we do think overall it would have a very positive impact on the industry. If you're interested in supporting our bill, the most important thing to do is to write to your members of Congress or call them. There is a link here to NHIA's advocacy tool. You can click on the link. It will help you automatically write a letter. If you're a patient and happen to be on the call today, it's critically important they hear from patients that this is a benefit that would improve the quality of life for patients, improve your ability to return to work, or if home infusion has had a positive impact on your life, sharing your story is incredibly impactful. If you're a provider, it's still important for you to reach out and talk about what your experiences are and the challenges you face serving Medicare beneficiaries and how that's different from how you're able to help patients with other types of insurance. So if you're a provider, you can also invite members of Congress to come visit your facility. Really helps for them to see how it's different from a retail pharmacy. And basically, our ask is very simple. Ask them to support and pass our bill. That's really what we need at this point more than anything. All right, I want to talk about Joe Fiandra next. This is a bill that was introduced by Representative Brian Fitzpatrick out of Pennsylvania. It had 6 co-sponsors. And basically, this is a really interesting bill. And, from an NHIA standpoint, we understand that almost all patients want better access to home infusion. And everyone who is on a drug that's not covered under the current pump benefit often struggles to get access. And so this is a bill that was passed to try to improve access for certain conditions that might meet these criteria. So basically what this does is it changes which drugs can be covered under the current EIP or current pump benefit. And what it would do is allow some drugs that require a healthcare professional to administer that drug to possibly add that drug to the EIP benefit. Today, the EIP benefit does not allow any drug that a healthcare provider has to administer to be covered. It's actually the opposite. The pump is what actually is a substitute for a healthcare professional, and the patient has to be able to use it independent of a healthcare professional. So this is a very kind of flips the policy on its head a little bit. But basically, an eligible drug to be included in the benefit under this criteria must require a pump, because again, this is a pump benefit, and it must be administered by a HIT services supplier, so by a company that is enrolled as a HIT services supplier. The drug must be administered at least 12 times per year. So that's a clue that they're targeting chronic drugs here. And it's not always clear in that how you would determine if a drug is going to be administered 12 times a year. So that will be an interesting thing to see how they determine that in rulemaking. Now that this has passed, basically what we expect to happen next is that CMS will interpret the law and express how they're going to implement it in their home health rule or a DME rule. And usually those rules come out in early summer, either late May or early June. That will give us an opportunity as the association to comment on that rule, agree or disagree, or make suggestions for improvements for how they're going to approach implementation. And then they'll finalize the rule in October or November of this year. The implementation date for Fiandra is no later than April of 2027. And so it has to be basically ironed out by the end of this year. And that's not going to allow a lot of time for home infusion providers to assess the implementation, determine whether they are interested in enrolling in the benefit if they're not already, in order to potentially serve patients that might be impacted by this policy. Now, while that's the implementation piece, there are more steps. And so I'm going to let Bill maybe cover this slide a little bit, because it's not automatic. Just because a drug might qualify under this benefit, just getting through the rulemaking process doesn't automatically add coverage for anything. So go ahead, Bill.
Yeah, as the current external infusion pump policy currently exists, it does not allow for coverage of healthcare professional administered drugs. So it would need to be modified in some way, either at the national coverage policy level or at the local level, to allow for that. And what they do is, based on how it's structured now and how historically it has been modified, is they will add some general coverage criteria that would need to be met in order for a drug to be considered for coverage. So we anticipate that they'll add additional generalized coverage criteria for HR 4993. And then they'll address individual drugs or therapeutic classes individually within the coverage policies. That's how it exists now. It's very specific. There's only about 35 drugs that are DME infused drugs that utilize a pump that are applicable to the HIT services benefit. So it's very small. It's only about 10% of all the drugs that are infused in the home by home infusion services providers. So in order for specific drugs to get added to this policy once implemented, they'd have to go through a reconsideration process. This is an application to get this drug or this drug therapy category added to those coverage policies. And it's an official process. It's called the LCD reconsideration process. And they're submitted to the Durable Medical Equipment Medicare Administrative Contractors. That's what DMEMAC stand for. And they evaluate those applications. They determine whether they're valid or not valid. And if they are valid, they move forward and develop proposed coverage criteria. And it's a very public, transparent process where that criteria they develop is always based on clinical evidence. It's always specific to the FDA approved conditions. So they'll talk about the drug, the circumstances under which it would be covered. And when that's proposed, they'll have a public meeting and a public comment period. And then they will take into account those comments and come up with a finalized coverage policy. And then they've got to give at least 45 days for that coverage policy to be enacted. It can at times include retroactive coverage, but it doesn't go into effect for 45 days after published. And this whole process really depends on how many applications are in the queue. Right now, there tend to be quite a few, and the ones we've been following that are IV pen related, that means intravenous, parenteral, or enteral nutrition. So there are dozens of policies under DMEPOS, and this LCD reconsideration applies to all of those coverage policies, not just EIP. So depending on what's in the queue, depends on how long it takes. Right now, it's running about a year.
Great, thank you, Bill. All right, so what's the impact then ultimately of, we call it Fiandra or HR 4993, which is the bill number. Basically, what we believe the impact here is that it could add a very small number of drugs to Medicare Part B, home infusion, the home infusion pump benefit, or EIP. And again, and the reason for that, reason we don't think this is going to add a lot of different new therapies to the benefit is that because there's not very many instances where a drug that is administered by a healthcare professional requires a pump. The healthcare professional somewhat replaces the need for a pump because they're there one-on-one with the patient. There's lots of ways to control an infusion rate. A lot of the drugs that might be considered for this policy have a fixed 1-hour infusion, 30-minute infusion. They're not things that the rate has to be adjusted frequently, or they're not infused at a very, very, very slow rate. So there's just not a lot of justification for the need for a pump in most situations. Now, there will be a few exceptions to that. But the other thing is that in the actual law, the need for the pump, actually not the need for the pump, but the need for the healthcare professional to administer it and the 12 dose per year requirement have to be explicitly in the FDA approved label for the drug. So there has to be some reference in that FDA approved label for the need for the healthcare professional and evidence of the dosing requirement. And so this is, I think, the way I would distinguish it. It's not a clinical practice policy. It's a prescribing information policy in terms of those two criteria. So basically, though, there is another provision in there that CMS is going to determine what infusion rate establishes the need for a pump when a healthcare professional administers the drug. This will be something they have to do as part of the rulemaking process. If we look for clues in terms of how they might do this, there is guidance out there for other drugs that are evaluated for addition to the EIP policy. And in the shaded area here is kind of taken from the direction given to the DME max about when a pump is needed. So the bar is pretty high. I would say that that's always going to be the top bar is the need for the pump because it has to go into a pump benefit. And then if the pump is determined to be needed, then you have to also go to the prescribing information to see if a healthcare professional has to administer it and if it's going to be dosed at 12 times per year. Anything to add there, Bill?
No, you covered it perfectly.
Okay. Sorry, Mike. Okay, so what kind of drugs might be impacted by this? And again, we are just speculating. We won't know for sure until CMS does the actual rulemaking on this. But if we just do our own research and say, well, what drugs are healthcare professional administered and they have a reference in the labeling for the use of a pump and they're given 12 times a year in almost all cases. Onpattro, Naglazyme, Lumazyme, these are drugs for enzyme replacement. And Onpattro is the drug that treats the condition that Mr. Fiandra had and that this bill is based on. So we think that primarily this bill was written specifically to capture drugs like this. There are other things, though, that could be wrapped into this, but there's lots of complications here because the Joe Fiandra bill links home infusion therapy services to the drug's eligibility for the pump benefit. So in order for the drug to be payable, it has to be administered by a HIT services provider or supplier. And there are conditions that make drugs eligible for HIT services. So we have kind of this circular kind of way of qualifying drugs for each of those benefits, and it's unclear for us at this point how CMS might reconcile some of those challenges. So an example of that is Restigo. Restigo is administered using a subcutaneous pump, but the administration rate for low doses would not be long enough to qualify the drug for HIT services, but HIT services are required to make the drug eligible for the Fiandra condition. So you can see how this gets very messy very quickly. And we, again, are not sure how CMS might reconcile some of those questions. We have sent CMS our view of this policy and recommendations about how to go about implementing it to try to minimize the amount of conflict that might exist between the current practice with the policy and this new set of conditions. Drugs that won't be eligible for this, in our view, are things like IVIG for conditions other than primary immune disease. Bill already answered a question earlier about how IVIG is covered under Medicare Part B with its own benefit. And CMS has said many times IVIG actually does not require the use of a pump for administration. A pump can be used, but is not absolutely necessary. Now, clinical practice may be different from that. However, we also know that certain things have to be indicated in the prescribing information. Most IVIG products do not have any reference for healthcare professional to administer IVIG, even though, again, we know in practice it's commonly done. So I don't think that we will see the IVIG products would be eligible for inclusion in the EIP benefit based on the current criteria as we understand them. And then there are other enzyme replacement drugs that we don't know how CMS might reconcile access to those, even though others may qualify. So an example of that is Lamzede. In that prescribing information, there's no explicit language requiring a healthcare professional to administer it. So it's going to be very interesting. Again, we have to go through rulemaking. It's not totally clear how they might reconcile some of these conflicts. We also do have concerns about access challenges for drugs that do get added to the benefit. And the reason for that is that if you look at participation in the home infusion therapy services benefit, the nursing benefit today, the access is very, very, very low. Very few providers are enrolled. Very few are actively taking patients and actively billing for visits. These drugs, we believe, would very much fit into category 3. We didn't cover categories here. We don't want to go into the details here, but we believe the category 3 is the category for the most complex drugs. If a drug is complex enough for a healthcare professional to need to administer it, it's going to qualify as complex. Now, CMS could create a whole new category for these drugs. We don't know what they're going to do yet, but if you look at the map here from the last CMS report that they published, there you can see that most of the country has no visits being performed for category 3 in the last few years. And we actually think this has probably declined since this report was published. And so that participation does not bode well for drugs that are added to this benefit. The other thing that, could be a delay is just the whole process for evaluating new drugs. We don't know how quickly that could happen. Based on experience with the process now, Bill did say there's a queue of things that have to go through DME reconsideration. It could be a long time before we see a drug added under the new criteria. And then finally, the deterrent here too is on the patient side of things. Patients will have a 20% coinsurance for the drugs added to this benefit. If that patient is in Medicare Part D today and maybe paying out of pocket for nursing services because there's no benefit for nursing there, they may be paying less today than they would under this new policy because their drug costs are capped at $2,100 a year, and nursing visits are relatively inexpensive compared to the 20% coinsurance for some of these very expensive rare disease drugs that could be captured by this policy. Now, obviously, some patients have supplements, but supplement access can vary state by state. A lot of these patients may be under the age of 65 as well. And so we think that the higher out-of-pocket cost could be a big deterrent here and maybe be an unintended consequence of adding drugs to this benefit. Anything else here, Bill?
Nope, I think you highlighted everything.
All right, so just to kind of wrap things up and then we'll take some questions. Side by side, looking at what these two bills do, I think it's pretty clear, hopefully after the presentation here, that our bill is actually focused on trying to fix some of the structural problems with the whole Medicare home infusion therapy services benefit. It focuses a little more on the services side of things, but it also does add drug coverage as well. So it would fix the lack of a services payment that is the big barrier for providers to participate in the benefit today. It would recognize the services that are not provided in the patient's home, explicitly recognizing pharmacy services. It would add coverage for IV antibiotics, which is expressed in the policy, and we don't think it wouldn't require that whole process of going through the DME max. It would be much more of a automatic coverage. I believe that would be started kind of through rulemaking. Obviously, our bill does not address these healthcare provider administered drugs. It's much more focused on the high volume drugs of IV antibiotics. And then finally, our policy would remove making the pump the prime criteria for adding drug coverage. It would allow then other less complex methods of administration that are used routinely today to administer IV antibiotics for non-Medicare patients, things like elastomeric pumps, IV, just being able to do IV push and syringe, gravity drip, things that are much simpler for patients to learn. So that's kind of a little side by side. So just to kind of say in summary, while the Joe Fiandra Access to Home Infusion Act has passed Congress, we do believe that it's going to be fairly limited in its impact on adding drugs to the benefit. And that's primarily because it continues to rely on the need for a pump and then also has some fairly strict provisions that require the presence of evidence in the FDA approved labeling. And then again, finally, just low provider participation in the benefit to serve patients. Where our bill, we do believe, goes a lot farther, fixes a lot of the fundamental problems with the Part B services benefit, and then adds access to potentially many more beneficiaries that we know are commonly treated at home today. So with that, we'll address some of the questions that are in the Q&A, and then if you have questions after the webinar, you're welcome to email them to me or Bill.
We do have a couple questions, Connie. I've been monitoring the Q&A.
Sure.
There are two, and they both are related to preserving patient access. Would this include all anti-infectives, antivirals, antifungals, or would there be exclusions?
There would be no exclusions. It would refer to the USP, or the United States Pharmacopoeia list of anti-infectives for eligible products, which should be fairly comprehensive in terms of, and again, it would be those that are administered IV. So it's not obviously going to address anything but the IV products. So if it's listed under the United States Pharmacopoeia as an IV, as an anti-infective, it would be eligible for the benefit.
And the second question is, for anti-infectives, which benefit / LCD would the per diem, and I think by per diem they mean the home infusion therapy services nursing benefit, be covered if approved? And if I could start with that one.
Please, go ahead.
The local coverage determinations are at the MAC level, and since the anti-infectives would be billed to Part D, the HIT services coverage would probably, I mean, it really depends on how CMS operationalizes this new benefit, but they certainly could look to the Part D dispensing activity and marry the HIT services payment to that. Now, keep in mind, HIT services is not currently billed to the DMEPOS. That's over in a different part of Medicare with the local Medicare contractors. But there is not currently, nor would I anticipate there would be a local coverage determination for it. They could create one, and if they did, it would likely be under the local MACs and not the DME MAC.
Great questions.
Yeah.
We'll hang out here for another minute or two to see if there are any other questions. Obviously, NHIA will have updates about what we hear from CMS as far as rulemaking goes on the Joe Fiandra bill. We'll have that information for our members. We did want to offer this to both members and non-members because we know that there are a lot of questions out there about the impacts of these policies. And so we do appreciate, again, everybody's participation today. If there are no other questions, we're happy to wrap things up. And again, feel free. Oh, is this recorded? That's a great question. I don't know. I think so. I see one of my team members is responding to that question. I believe it probably is. And then we may be putting it out on our YouTube channel so you can access it afterward. And again, the slides are available in the chat. Anything else?
You will get a link to the presentation and slides after this presentation. So I think that helps to clarify the slides and the access.
I'm going to stop sharing for a minute. We have another question about, will the bill address coverage for oncology immunology drugs? It's a really good question. I have reviewed the FDA labeling for, I would not say a lot of oncology drugs, but we do publish a home infusion therapy drug list at NHIA, and that list is publicly available. And so I did review the drugs that have been added to that list, and that list reflects drugs that have been reported by our members to have been administered in the home. So meaning if someone, often what happens is a home infusion company will get a request to administer a drug they haven't done before. They will refer to our list to see, has anyone else administered this in the home? Has it been done before? And that's what that list functions as. And so we did review a number of oncology drugs to see, do they meet the Joe Fiandra criteria? And quite honestly, of the oncology drugs that I have reviewed, they may meet some of the criteria, but not all of the criteria. So, for example, there are some that I have seen that reference the need for a pump, that reference the need for a healthcare professional, but it's unclear how many doses a patient is intended to receive. And as you can imagine, a lot of times with oncology, the treatment regimens can be highly variable, and the number of doses may depend on the number of cycles they need. And so it's unclear to us right now, and this will be something that will somewhat be dependent on how CMS interprets the rule, whether or not any oncology immunology drugs could be added to the home infusion EIP policy under the Fiandra criteria. The Preserving Patient Access to Home Infusion Act does not in any way address oncology immunology. I hope that answers your question. We do have a few more minutes, so if you have a burning question, feel free. Anything else you can think of, Bill, before we wrap up?
No, I might add to that oncology immunology. There's nothing specific that addresses the therapeutic class, but if that particular drug met the conditions of the bill, it may be captured in coverage. And I know that the frequency of administration and healthcare professional can vary greatly amongst those biologics.
That's a great point. So again, it's not about any particular class, whereas our policy is primarily focused on a class of drugs that where there's a large unmet need. So I think, just a little background since we have a few minutes, that this Joe Fiandra policy was introduced first by CMS in a DME rule. And there are comments on the record about how people felt about that rule when it was first introduced, and it was never moved forward by CMS, and then it reappeared as legislation. So, I think there were concerns at the time of how would you determine whether a drug should even be administered through home infusion using this policy. So there were a lot of questions about what drugs would be captured by this, which are good questions.